Welcome to the co-joint seminar. My name is Ilona Schmalfuss. I'm a professor of radiology at the University of Florida in North Florida, South Georgia Veterans Health Administration. At the same time, I'm also the president of the ASHNR. I would like to refer you now to Dr. Qureshi, who is from the ASHNR and will be presenting the next slide.
Thank you very much indeed, Ilona. Good morning, afternoon, and evening, and welcome everyone to this brand new exciting project. I am Salman Qureshi on the Executive Committee and Education Committee of the European Society of Head and Neck Radiology. I'm also the liaison for our committee with American Society of Head and Neck Radiology. I'm originally from Manchester, but working in Hamad Hospital in Doha in Qatar in the Middle East. So without doubt, this is genuinely a truly global venture. So this is our first joint webinar, and this is part of a long-term planned collaboration between our two great societies. Can you, next slide please, Julie? So welcome everyone to this. Just to give a brief background, our committees have been in discussion with each other over the last couple of years of seeking ways to work together. It started with discussions at RSNA a couple of years ago with Debbie Schatzkes as well as Christine Glastonbury and Rick Wiggins. After discussions with both executive committees, we plan to have joint sessions at our annual meetings, but sadly, due to global circumstances, we have not been able to fulfill this yet. But it is still planned for future meetings. These webinars represent another planned joint project and are not just a response to the pandemic. We are planning to systematically go through the subject matter one by one in head and neck radiology, and then give a review of the imaging, anatomy, and radiology pathology for each of those chosen subjects. These will be once a month with breaks in August and December. Therefore, to get through the subject matter will take a few years, and that's why I reiterate that this is a long-term collaborative project. There are so many people who have helped set up this project on both sides. In particular, as well as Ilona, I have to say a big thank you to Christine Glastonbury and Callie Robson on the American side, who have worked tirelessly to get this up and running, and who have had to put up with many emails, WhatsApp messages, odd-timed phone calls, and multiple Zoom meetings to get this organized. There have been events and always available despite just having finished their own online version of their annual meeting and all the organization involved with that. And on our side, many thanks to Minerva Becker as Chair of Education and Bert DeFore as President-elect for their continual support of this fantastic project. Also thanks to the social media teams on both sides in Nick Kuntz and Phil Tuska, and also thanks to both offices as well as Christy, Julie, Erica, Anka, and Wolfgang, and everyone else. There are many others as well. Next slide, please, Julie. Now I'll hand you back to Ilona.
Thank you, Dr. Qureshi. I can only echo your words. We are very, very excited about this collaboration, and this will not be starting only with this webinar series, but also in person as soon as we can resume our meetings. We are planning to have exchanges of speakers so that we can co-join our societies more closely together in a collaboration across the ocean. Now some housekeeping items. Use the QA panel to ask questions to the presenters, and we will be trying to answer those questions during the presentation or after the presentation. And please use the chat box to discuss and connect with your fellow attendees. This has been very successful at the recent ASHNR meeting. People literally connected across the country, across the world with each other, and even planned projects together. So we would like to encourage that engagement in this webinar series as well. If you do not want to see any chat or alerts messages, you can minimize the chat box and just simply ignore it. Thank you. Back to you. Next slide.
You can carry on with this one.
Okay, CME credit. You can claim CME credit for this activity. And this is in accordance with the essential areas and policies of the Accreditation Council for Continuing Medical Education through the joint partnership with American Society of Neuroradiology and the American Society of Head and Neck Radiology, as well as the European Society of Head and Neck Radiology. Wow, this was a mouthful. The American Society of Neuroradiology is accredited by the ACCME to provide continuing medical education for physicians. The American Society of Neuroradiology designates this enduring material for a maximum of 1 AMA PRA Category 1 credit hour. Physicians should claim only the credit hours with the extent of their participation in the activity. Following the webinar, please go to the website as indicated on the bottom of the slide to claim your CME credit. Thank you. Now let us move to learning objectives. Upon completion of this activity, participants will have strategies to understand laryngeal anatomy, especially as pertains to CT and MRI imaging, will know anatomic landmarks and structures that bear significance in the context of cancer imaging, to understand the CT and MRI features of characteristics, patterns of spread in squamous cell carcinoma of the larynx, and last but not least, to learn how to systematically describe the essential radiology findings in a clinical relevant report.
Okay, so I'll just run through the plan for the future. So as I mentioned, these are monthly webinars. So these are the dates for the next 4 webinars. The October 20th webinar, the topic will be hypopharynx and cervical esophagus. More details will follow. Then the November webinar session will be on the oropharynx. And then we will have a short break for December to incorporate RSNA, Christmas, Hanukkah, New Year, and Thanksgiving, because I understand Thanksgiving is a big deal to the Americans. Thereafter, the topic in January will be nasopharynx. Therefore, we will have covered larynx and pharynx systematically by that period of time. We will keep you posted with details of these future topics. Next slide, please, Julie. Now, I'm just going to take this opportunity just to plug a few events, if that's okay, or a few things that we are still organizing. Now, you can get up-to-date information from our website and also by following us on Twitter at ASHNR Society. Actually, on mentioning Twitter, don't forget, you can also follow the Americans at ASHNR Society, but we on the European side want to overtake the Americans in terms of numbers of followers, so please help us with that aim. Sorry about that. Anyway, back to the slide. Since we are not able to get together this year at our traditional annual meeting, Professor Soraya Robinson from the Executive Committee and ESHNR are excited to bring you 20 hours of on-demand education in the form of pre-recorded webinars starting 24th October. This is only for €50 if you're a member, which is just less than $60. Next slide, please, Julie. We also have our own monthly webinars, which have been running since 2018, and this year's program was planned in advance at the beginning of the year, and so still are continuing. In many ways, the next session actually solidifies the relationship between our 2 societies, because we have Ashok Srinivasan from Ann Arbor in Michigan, speaking on diffusion and perfusion imaging in the head and neck, followed by November by Steve Colley from Birmingham. That's the original Birmingham in the UK, not the pretend one in southern USA. Sorry, Phil Chapman. Anyway, Steve's talk is on head and neck infections. Then in December, Bernard Schucknecht will be speaking on Meniere's disease. Next slide. And then one of our associate member societies, the British Society of Head and Neck Imaging, are running their own educational webinar series. And the next one is on the 15th of October with Sri Ram Vidayanathan on parathyroid imaging. Next slide, please. Okay, so I'll hand you over to Ilona to introduce Amy. Now time for the main event.
It is my pleasure to introduce Amy Juliano, who is the Director of Research and Academic Affairs at the Massachusetts Eye and Ear Infirmary, as well as an assistant professor at the Harvard University. Amy will be talking to us about laryngeal anatomy. Welcome, Amy. Thank you.
The introduction, and thank you to the ASHNR and ESHNR for the invitation and honor to be part of this webinar series. First, I'll confess I was panicking for quite a bit for the last few weeks because I'm scheduled to speak alongside Dr. Minerva Becker, who is a recognized authority in all things larynx. So I will just do my best, and for the next 25 minutes, I will discuss anatomy of the larynx to pave the way somewhat, I hope, for the next lecture on pathology. First, let's talk about the functions of the larynx. So there are 3 main things. One is to maintain an airway, which means it has to stay open. Prevent aspiration, which means during swallowing, it has to be able to close. And phonation, which means there has to be moving parts and it has to be able to move. So that sounds like a pretty complicated design, and let's see what it looks like. On laryngoscopy, here we can see the larynx, and the person is talking, phonating, and you can see it move. So it's so complicated, and it's intricate, and it is unexpected in the way it looks. There are crevices, and folds, and creases, and all these different parts. And really, this is kind of like a labyrinth. So if you were to think about a third labyrinth outside of the temporal bone, this is kind of like a fleshy third labyrinth. In imaging, we have to break down 3D structures into 2D slices to look at them on cross-sectional imaging. And when something is this complicated, we really need to image in a very reproducible way. And we need to learn about landmarks. That way, whenever we see anything, whether it's anatomy, pathology, once we see these landmarks, they are our anchoring points, and they're going to save us. So we know where we are, and we can use them to help us navigate our way through the larynx. So to discuss laryngeal anatomy, I have broken it down to these following categories. And I want to point out that for mucosa, the clinician can see under direct inspection. It's the surfaces. However, cartilage, ligaments, and membranes, spaces, those they cannot see, and they're really within the domain of imaging. First, let's start with the mucosa, and we'll start with the true chord. Here's a photo from a laryngoscopy showing the true chords, which are the inverted V-shaped structures. Now, the laryngologist will refer to the true chord as just the vibrating edge, whereas the rest of it is the true vocal fold. In radiology, we tend to call the whole thing true chord, and that's okay, we can stick with that terminology. Now, let's see what comprises the bulk of the true chord. There's a muscle there, and the muscle is called the thyroarytenoid muscle. The medial part of this muscle is the vocalis muscle. The yellow is the vocal ligament, and that is the structure that can tense, that can stretch, that can have some vibration to it to help with phonation. The vocal ligament attaches in the back to the vocal process of the arytenoid cartilage, which is the base of the arytenoid cartilage, so the lower part of it. Along the vocal ligament, there is a structure called the macula flava. In fact, there is one in front and one in the back. And that is just a focally more dense coalescence and thicker fibers of the vocal ligament. And on this photo here from laryngoscopy, you can actually see this whiter part. That is the macula flava. At the very front of the vocal ligament, as it inserts into the mid portion of the thyroid cartilage, that is the Broyles ligament. The Broyles ligament is what the part of the vocal ligament that goes right through to the thyroid cartilage, where there is no perichondrium, and that is the level of the anterior commissure. Here is the CT image axial showing the level of the true chord. So here you can see the arytenoid cartilage, a bit of the cricoid cartilage, so you know you're at the cricoarytenoid joint and the base of the arytenoid cartilage. And that is where the vocal process of the arytenoid is, what the vocal ligament attaches to. So we know we are at the level of the true chord. That is a landmark. Now, there is no perichondrium at the anterior commissure, which means it's an access point for tumor to invade right into the cartilage. So when there's a tumor in the anterior commissure, as it grows, there's a higher chance for it to invade into the cartilage. On imaging, we need to make sure the acquisition is done during quiet respiration, because that is when the true chords will be not opposed to each other in the midline, but a little bit separated in paramedian position. That way we can actually see the surface and the contour of the true chords. Here is a patient with a lesion in the anterior commissure, and you can see it has invaded into the thyroid cartilage and beyond into the extralaryngeal space. So propensity for anterior commissure lesions as they grow bigger to invade the cartilage and then go extralaryngeal. Now I want to thank Matt Nonheim, who is a larynx surgeon at my hospital, for this. This is a cartoon drawing of a coronal section through the larynx. And now if we focus at the true vocal folds and look at the histology, we will see these different areas of different color. The purple is the squamous epithelium. Deep to that is the lamina propria, and there are 3 layers of lamina propria. The superficial layer of lamina propria is this creamy orangey color, and that is filled with, this is gelatinous material. And that is in an area called Rankus space, or a lot of our surgeons call it Ranke's space. The intermediate and deep layers of the lamina propria is this kind of bluish blackish layer, and that is the vocal ligament. Deep to that is the thyroarytenoid muscle. So when we phonate, what we're doing is actually pushing air out of our lungs under pressure. And this air column that is pushed with pressure traverses through this rima glottis, or the lumen of the glottic larynx. And as it does so, this pliable gelatinous stuff just kind of flops around and vibrates. And that is what allows sounds to be made. The vocal ligament can tense, can stretch different length to moderate the type of sound that comes out. But the gelatinous material in rhyncus space is what actually allows the vibration to happen to allow us to phonate. Kind of like that. Vibrating edge, because there is that gelatinous floppy material within rhyncus space. So here is a histologic section and MRI of cadaveric specimen through the larynx in a coronal plane. And you can see the muscle, the thyroarytenoid muscle, that is at the level of the true vocal fold. Now that is the glottic larynx, but there is actually a strict definition to the glottic larynx. It starts at the apex of the laryngeal ventricle, or some would just say the top of the true chord. And if you could drop a line down and you measure it, it spans 1 centimeter in height. At the end of the 1 centimeter is where the subglottic larynx starts. Here is a coronal CT image, and here comes my requisite Marge Simpson. This was first described by Dr. Curtin. And you can see that Marge's neck on either side are the true chords, and Marge's ears are the laryngeal ventricles. Now let's talk about the false chord and ventricle. Here's laryngoscopy showing again the true chords, and above the true chords are the recesses, which are the laryngeal ventricles, and above that, the false chords. On this MRI, we can see the laryngeal ventricles, and above that false chords, mostly fat in the paraglottic space. Histologic specimen, again showing the muscle, thyroarytenoid muscle, and then mostly fat at the false chord level. The ventricular ligament is the edge of the false chord, and the ventricular ligament inserts posteriorly to the superior process of the arytenoid cartilage, which is the tippy tip of the arytenoid. Because of that, now we can understand that the arytenoid height actually spans the ventricle height, because the upper aspect of the arytenoid is where the ventricular ligament attaches to, false chord, and the base of the arytenoid is where the vocal ligament attaches to, the true chord. The quadrangular membrane is a sheet we will talk about later, and it inserts inferiorly into the ventricular ligament. The ventricle is important. It's a key landmark in description of larynx pathology, especially in the context of cancer. And if there were to be consideration by surgeons to do a voice-sparing laryngectomy, the ventricle is a very important location to look. Here is a coronal image showing what doesn't really look quite like Marge. What's happened to one of her ears? It's gone really high up. That is the laryngeal ventricle, but the edge of it keeps going up, and that is called the ventricular appendix. In little kids, in babies, that's more prominent, and as we grow, the growth rate differs in different portions of the larynx, and the ventricular appendix becomes less apparent. So now, armed with that knowledge, let's see what happens when we look at a CT and we're scrolling through axial images. How can we tell where the false and true chords are on an axial CT? What are the landmarks? First, here's an image showing the epiglottis, the median glossoepiglottic fold, and on either side the vallecula. Here's the hyoid. So we know we are too high because the vallecula is part of the oropharynx, and the floor of the vallecula is the start of the larynx, where there's the hyoid bone, and there starts to be the hyoepiglottic ligament, which forms the roof of the larynx. So this is too high. We're not there yet. We're getting closer. The valleculae are getting smaller, so we know it's going to be the floor of the valleculae soon. And now, finally, we're at the level of the hyoepiglottic ligament. There's no more vallecula. There's the hyoid bone, and this starts the larynx. So there is the infrahyoid portion of the epiglottis, which is part of the larynx. Next, we start to see airy epiglottic folds, and I want to point out the fat at that level. In the front is the pre-epiglottic fat, and as you go to the side, you have the paraglottic fat. Next image, there is still fat, and when there is fat, as we can see on this drawing, that is at the level of the supraglottic larynx. As we keep going down lower, the fat starts to get effaced. There's not as much fat now. Sometimes there's a skinny sliver right off to the side, but most of it now is going to be the thyroarytenoid muscle. So we are starting to get to the true chord level, and in fact here we can see a little bit of the ventricle. So we're probably right at the juncture. Next image down, we can see the bottom of the arytenoid cartilage and the top of the cricoid cartilage. So we know we're at the cricoarytenoid joint. So again, the vocal ligament inserts to the base of the arytenoid, and that's how we know we're now at the true chord level. So some people will say when you see three cartilages at the same time, thyroid, cricoid, and arytenoid, that's your index image of the true chord. Next, we are still probably at the level of the true chord. We can still see a little bit of the arytenoid cartilage, but now we're seeing much more of the cricoid cartilage. As we go lower down, now we see much more of the cricoid ring. And notice also the lumen now is more of an oval, and that is when we're at the subglottic level. Now we don't even see the cricoid cartilage anymore. We're getting into the trachea. So we now are out of the larynx because the bottom of the larynx is at the bottom of the cricoid. That demarcates the inferior boundary of the larynx. So here are our index images. When we see fat, we know we're at the supraglottic larynx. When the fat is gone and we see all three cartilages, but really it's because we see the cricoarytenoid joint. So we know we're at the base of the arytenoid where the vocal ligament inserts. We're at the level of the true chord. And now when we see most of the cricoid cartilage, the lumen is an oval, we're in the subglottic larynx. So the pear tomato, the teardrop shape, true chord. The oval, like a cherry tomato, we're in the subglottic larynx. So our landmarks are going to be the paraglottic fat, the arytenoids, which span the height of the ventricle, the base of which takes us to the level of the glottic larynx or true chord, and then the cricoid ring, which takes us to the subglottic larynx. Now pay attention to the subglottic larynx. It should be paper thin. The air column should be right up against the cricoid cartilage. If there is any soft tissue thickening at all, it's going to be abnormal, and it's possible that this represents tumor. Now, because we rely on landmarks so much, we have to make sure we image and we view the images always in the same plane. And that is going to be the plane of the true chord. So we have to reformat our axial images so they line up with the plane of the true chord. So always make sure we tell the text, reconstruct in a plane parallel to the plane of the true chords. Some people use a disc, C4, C5 level disc as the plane, or if you can see the air in the ventricle, that tells you the flat surface of the true chord. Next, let's move on to cartilage framework. There's the cricoid, arytenoid, and thyroid. And if we look to the inside of it, we can see here again the arytenoid cartilage, and again the vocal ligament going to the vocal process, which is at the base. These are the corniculate cartilages sitting at the top, and we usually cannot see them on imaging. And these are the cuneiform cartilages, comma-shaped. Also, we cannot really see. They look like a bump on the laryngoscopy along the fold. The vocal process, we already mentioned, insertion point for the vocal ligament. There is something called the triticale cartilage, and that is a tiny focus right at the thyrohyoid ligament at the back. The oblique attachment line is this line along the thyroid cartilage, which forms this sort of a contour, and that's where a lot of the muscles attach. And where the muscles attach, there's increased vascularity, and that tends to be where ossification starts. The cricothyroid gap is this area in front where there is membrane, and we will talk about that in a little bit. The cricoarytenoid unit is the basic functional unit of larynx that helps for phonation. The cricothyroid gap is a weak point. It allows for a tumor in that location to extend anteriorly to an extralaryngeal location. I want to thank Matt Nonheim again for these animations, and they show that the posterior cricoarytenoid muscles are what are responsible for helping abduction of the vocal folds for respiration. So they are supplied by the recurrent laryngeal nerves. So you can imagine if there is injury to the recurrent laryngeal nerve, the ipsilateral true vocal fold would not be able to abduct, so we get a vocal cord paresis. And at the same time, over time, the posterior cricoarytenoid muscle can undergo fatty atrophy. So that is what we can see on imaging. This patient has left true cord paresis, and we can see the big laryngeal ventricle on the left. But at the same time, not only that, there is also asymmetry to the posterior cricoarytenoid muscles, and it is atrophied and fatty replaced on the left side. And at Mass Eye&Ear, we call that the Romo sign, and we named that after our colleague Laura Romo, who described this in a paper a number of years ago. Now, of course, the other sign we're more used to seeing is atrophy, or a smaller caliber of the thyroarytenoid muscle, which is responsible for adduction and phonation. So here we can see a patient with enlarged left lateral laryngeal ventricle and a attenuated true cord because there is atrophy of the thyroarytenoid muscle. Now, I just want to point out that cartilages can calcify and ossify in very variable ways. Here we can see 6 different patients, and there's no really correlation with age. There is not really much symmetry sometimes. Notice how this is sclerotic on the left and not on the right. And these are all patients without laryngeal cartilage pathology. So as you can see, the ossification process and pattern can be very variable and often asymmetric, and that can lead to difficulty and challenges when assessing for tumor invasion into cartilage. Now let's take a moment to look at imaging appearance of normal cartilage. So here I have CT and MRI on the same patient. For MRI on both T1 and T2, non-ossified cartilage has intermediate to low signal. So here on the pre-GAD T1, it is intermediate in signal corresponding to the non-ossified cartilage on CT. It is also intermediate to low signal on T2 and does not enhance. For ossified cartilage, basically it looks like bone. So the rim, the cortex, is going to be very hypointense, whereas the center is going to follow fat signal because it's basically fatty marrow. So here you can see bright on T1, suppresses with fat suppression, and no enhancement. So we should never see enhancement inside the cartilage. If there is any enhancement in the medullary cavity, we have to suspect tumor, especially if we can see that it is isointense to adjacent tumor. The epiglottis is also cartilage, but it is yellow fibroelastic cartilage, so it's more pliable and it can snap back. So that is what can help us close the larynx when we swallow and open it when we breathe. So here we can see the epiglottis. Another image showing these little perforations in the infrahyoid epiglottis. The infrahyoid epiglottis with these perforations means that there is poor resistance to tumor invasion. So if there is tumor in the laryngeal surface of the epiglottis, the tumor can go through these perforations to the lingual surface of the epiglottis. Here is a sagittal CT image showing a tumor that is growing along the laryngeal surface of the epiglottis and is growing anteriorly to try to invade into the pre-epiglottic space, and it continues up to the tip of the epiglottis and even into the base of the tongue. Now let's take a look at ligaments and membranes. And we'll start with the hyoepiglottic ligament. It connects between the hyoid bone and the epiglottis. And on the CT, it's really hard to see, it's hard to define, but it forms the upper border of this fat, in this fatty space, which we will describe in a little bit. Here is an MRI of a cadaveric specimen. We can see these lines. These are the hyoepiglottic ligament. In front, this is the hyoid bone. This is the epiglottis coming down towards the root, which is called the petiole. The hyoepiglottic ligament serves as a barrier to prevent tumor from spreading from the larynx, from the pre-epiglottic space, upwards towards the base of tongue. Next is the thyrohyoid membrane, and it is this sheet that goes between the hyoid bone to the thyroid cartilage. And at the back edge of it is the thyrohyoid ligament. Now within this is the trapezial cartilage, which we mentioned earlier, and it can calcify. So usually we don't really see it, there's not much significance. The only thing is if we were to get a plain film, it can look like a foreign body if it is calcified. Here's an axial CT image showing an air pocket. And remember the ventricular appendix earlier? Well, if that gets distended and air-filled, that is what we call a laryngocoele. And a laryngocoele can be internal if it is entirely medial to the thyroid membrane, or if it protrudes lateral to the thyroid membrane, then we call that a mixed internal and external laryngocoele. Here's another patient. Again, we see this structure that is in the paraglottic space. And that is when the ventricular appendix is dilated. And now it's not just air-filled, but filled with fluid. And we can call this a fluid-filled laryngocoele or a saccular cyst. This one here is demarcated and confined by the thyrohyoid membrane. When we see a laryngocoele or a saccular cyst, we have to be very careful because maybe there's a ball valve phenomenon such that the opening of the ventricle is actually obstructed. So things behind it gets backed up. Fluid cannot drain even though secretions build up or air gets accumulated. And sure enough, in this patient, there is a ventricular squamous cell carcinoma that is obstructive, leading to the formation of this saccular cyst. Here's a patient with a tumor in the paraglottic space, and this one is invading past the thyrohyoid membrane out towards the strap muscle. Now the cricothyroid membrane we have mentioned briefly before. It's the gap between the cricoid cartilage and the thyroid cartilage, and it's a weak point where tumor can spread, as you can see in these two patients going anteriorly through the cricothyroid membrane to an extralaryngeal location. The quadrangular membrane is a sheet. We mentioned earlier already that inferiorly it attaches onto the ventricular ligament, which is the edge of the false cord, and on the top it attaches along the edge of the airy epiglottic fold. The quadrangular membrane is represented here in this drawing as a yellow line, and on histologic section, it's really hard to see, but lateral to the quadrangular membrane is fat, and that is the start of the paraglottic space. On imaging, we cannot see the quadrangular membrane, and in fact, in surgery, oftentimes they can't really see the quadrangular membrane very well. The conus elasticus is the barrier that helps to contain tumor medially. It's a bit tougher. The upper part of the conus elasticus inserts to the vocal ligament, which is the medial edge of the true cord, and inferiorly it continues around the medial edge of the thyroarytenoid muscle to insert to the medial inferior cricoid cartilage. On histologic section, it's hard to see, but it follows along that course. On imaging, we definitely cannot appreciate the conus elasticus, but again, it demarcates the medial aspect of the paraglottic space, and it forms a barrier to tumor going from the mucosal surfaces laterally. Now let's go to spaces. The paraglottic space is an important area to note because involvement of the paraglottic space by tumor upstages a tumor. So we already mentioned before, the paraglottic space is whatever is lateral to the quadrangular membrane and the conus elasticus. So it's the area where there is fat and where there is thyroarytenoid muscle and lateral to that. So here's an example of a patient with tumor in the paraglottic space. It was a tumor that started in the ventricle. The true cord was actually normal, and it went laterally and up in a submucosal manner through the paraglottic space. Now let's take a look at the pre-epiglottic space. Here's a drawing showing the fat inside the pre-epiglottic space, and it is demarcated by the hyoepiglottic ligament, forming its upper boundary, the thyrohyoid ligament, and the thyroepiglottic ligament, or the petiole, which is the root of the epiglottis. Here is a sagittal MR image showing the fat that is bright on T1 weighted sequence within the pre-epiglottic space. The pre-epiglottic space is very rich in lymphatics, so if a tumor were to extend into the pre-epiglottic space, it can very quickly go into nodal metastasis. So involvement of the pre-epiglottic space by a tumor upstages a tumor. I would just like to point out that the paraglottic space extends into the aryepiglottic folds posteriorly, and the paraglottic space merges with the pre-epiglottic space anterosuperiorly. And these have implications for submucosal spread of tumor, as I'm sure you will see in the later lecture, and as evidenced in this patient here on the CT. So just a quick word about lymphatic drainage of the larynx. Supraglottis tends to go up. Subglottis can go up, but also down towards level 6. A characteristic node is the Delphian node, which is anterior to the cricothyroid membrane. And interestingly and importantly, the glottis has very little lymphatic drainage. So if there's a tumor in the glottis, first of all, it'll be symptomatic early because the voice will change. And second of all, there is not as much of a chance of lymphatic nodal spread of tumor. Again, the pre-epiglottic space has a lot of lymphatics, so when tumor spreads into the pre-epiglottic space, there's a high chance of cervical metastasis. So in summary, we just have to know the anatomy well. And if you think larynx anatomy is hard, it's because it is. I think it is. That's why we need to image consistently. We need to know the landmarks. And then as pertain to tumor imaging, we have to recognize certain structures that are barriers to tumor spread, that are protective, and then there are weak links to tumor spread. And in my mind, I imagine the larynx as the third labyrinth after the bony and membranous labyrinth in the temporal bone. But it's even harder than that because the larynx moves and the temporal bone doesn't. Finally, I want to thank Hugh Curtin, Callie Robson, Mary Beth Kinane, and Matt Onheim for their support. And a big thank you to Salman Qureshi, Christine Glastonbury, Debbie Schatzkas, Ilona Schmalfuss, and Callie Robson for the opportunity to speak today. Thank you so much.
Thank you very much indeed, Amy. Thank you for an excellent presentation. And we've been looking at the comments that are coming through. And in particular, there was reference to your animations, the animations that you had, which were really very nice. I'm going to introduce our next speaker so we can go straight into the next talk. When we first discussed with our American colleagues, it was felt that we had to get Minerva to speak and the topic had to be larynx to get real expertise. So Professor Minerva Becker studied medicine at the University of Bern in Switzerland and specialized in radiology at the Insel Hospital, University of Bern. Early in her career, she specialized in head and neck radiology, and many of her scientific publications focused on radiology pathologic correlation. She is the author of over 150 scientific publications and review articles, and she is co-editor of Valvasori's Head and Neck Imaging. She is the recipient of over 25 international and national scientific awards, reviewer for 12 scientific journals. Her main fields of research include head and neck oncology, as well as many others. She is professor of radiology and head of the imaging unit of the Head and Neck Maxillofacial Radiology Diagnostic Department at the University of Geneva. And she's an enthusiastic teacher with over 400 invited lectures. As chairman of the Education Committee of the European Society of Head and Neck Radiology, she is in charge of the European General and Subspecialty Training Curriculum in Head and Neck Radiology and of the European Board in Head and Neck Radiology Diploma. She is the past president of ASHNR. It gives me great pleasure now to hand over to Minerva's lecture.
Ladies and gentlemen, dear colleagues and dear friends, it's my great pleasure to talk to you today about imaging of laryngeal pathology. In this webinar, I will speak about imaging of laryngeal tumors. This is my disclosure statement. Over 95% of tumors arising in the larynx are squamous cell carcinomas. Imaging plays a crucial role for TNM classification, for the pre-therapeutic workup, and also for follow-up purposes. Tumors are evaluated using a combined approach. The mucosa is assessed by means of endoscopy and biopsy, whereas deep tumor spread is assessed by CT and MRI, and this is what I'm going to talk about in this webinar. Lymph nodes are evaluated by means of ultrasound with or without fine needle aspiration cytology, CT, MRI, or PET-CT, whereas distant metastases are usually evaluated with CT or PET-CT. What is the characteristic aspect of laryngeal cancer on contrast-enhanced CT? Tumors manifest either as moderately enhancing, diffusely infiltrating lesions, as in this supraglottic cancer. They can also manifest as exophytic infiltrating lesions with a stronger enhancement. And finally, tumors can manifest as moderately enhancing lesions surrounded by a hypervascular stroma. This hypervascular stroma either corresponds to hypervascular tumor areas or peritumoral inflammatory edema. And the distinction on contrast-enhanced CT images can be quite challenging. What is the MRI aspect of laryngeal cancer? You have an example here of a subglottic tumor with an intermediate signal on T2, low signal on T1, and moderate enhancement after administration of gadolinium. If you use subtraction images by subtracting T1 from T1 with gadolinium, then you will see that the tumors tend to enhance less than the surrounding inflammatory edema. The distinction between tumor and inflammatory edema is best possible on T2-weighted sequences as well as on the ADC map. You have an example here of a bilateral glottic cancer, and you see that the tumor has an intermediate signal on T2 and a low signal on the ADC map because squamous cell cancers have a restricted diffusivity. As opposed to squamous cell cancers, inflammatory edema has a high signal on T2, and it also has a high signal on the ADC map because there is no restricted diffusivity. The distinction between tumor and edema is not always that obvious on contrast-enhanced images, as you can see from this case. In order to write a clinically relevant CT and MRI report that is really useful to your ENT colleagues, you should use a systematic approach and, if possible, a checklist. Your report should include the following items. First of all, which subsites of the larynx are involved? Is the preepiglottic space invaded? The paraglottic space? What about the laryngeal cartilages? And what about structures beyond the larynx, such as the trachea, strap muscles, thyroid gland, esophagus? Is there encasement of the carotid artery? And so on. I would now like to go with you systematically through the different sites and deep spaces that you have to mention in your report. And I'll start with the preepiglottic space. The preepiglottic space is typically invaded by ventral supraglottic cancers that arise from the laryngeal surface of the epiglottis. These tumors tend to spread through the natural perforations of the epiglottic cartilage into the preepiglottic space. Preepiglottic space invasion influences the T classification. Tumors are then staged as T3. It affects the surgical procedure as well as the outcome after radiation therapy. How do we diagnose preepiglottic space invasion? The preepiglottic space contains normally fatty tissue as well as some minor salivary glands. So whenever we see replacement of this fatty tissue of the preepiglottic space by an enhancing tumor mass on CT or on MRI, as in this case here, then we diagnose preepiglottic space invasion. Both CT and MRI are accurate for the detection of pre-epiglottic space invasion, and the degree of spread of tumors into the pre-epiglottic space as assessed by CT or MRI corresponds very nicely to what is seen afterwards at histopathology, as you can see from this case. Lateral supraglottic cancers, that means tumors that arise from the laryngeal surface of the areoepiglottic fold, from the ventricle or false chords, tend to spread laterally into the paraglottic space. Paraglottic space invasion affects the T stage. Tumors are then staged as T3. It affects the surgical procedures as well as the outcome after radiation therapy. So how do we diagnose paraglottic space invasion? Normally the paraglottic space contains fatty tissue. So if we see replacement of this fatty tissue by an enhancing lesion on CT or MRI, or by an intermediate signal intensity tumor on MRI, then we diagnose paraglottic space invasion. You can see an example here of a supraglottic cancer on CT and MRI. There was invasion of the paraglottic space that was confirmed afterwards histopathologically. Both the pre-epiglottic space as well as the paraglottic space are important pathways for tumor dissemination. Transglottic spread can occur anteriorly along the pre-epiglottic space, and it can also occur laterally along the paraglottic space. In both cases, supraglottic cancers can gain access to the glottic level, and from the glottic level beneath or in between the thyroid and the cricoid cartilage into the soft tissues of the neck. Glottic cancers arising from the free edge of the true vocal cord can spread anteriorly towards the anterior commissure and then to the contralateral vocal cord, or they can spread laterally into the paraglottic space. Anterior commissure invasion affects the surgical procedure as well as the outcome after radiation therapy. How do we diagnose anterior commissure invasion? At imaging, you will see thickening of the region of the anterior commissure, usually above 2 millimeters, and tumor is seen bilaterally involving both vocal cords. These are two examples, two different patients with anterior commissure invasion and bilateral involvement of the true vocal cords. However, you have to be careful when you diagnose anterior commissure invasion, because this is possible only if CT was acquired with an open glottis. Whenever CT is acquired with a closed glottis, then you will get artifactual thickening of the anterior commissure. So this is a pitfall you have to be aware of. Subglottic invasion can occur via the anterior commissure as tumors spread downwards, or along the free edge of the true vocal cords. Subglottic invasion is important because it affects T classification, the surgical procedure, as well as the outcome after radiation therapy. How do we diagnose subglottic invasion? Whenever you see a protruding lesion into the laryngeal lumen at the level of the cricoid cartilage, you diagnose a subglottic invasion. You have here two different examples, one patient with major subglottic invasion as shown on CT, another patient with more subtle anterior subglottic invasion demonstrated by MRI. Now let's have a look at neoplastic cartilage invasion. Why is it so important? First of all, because it affects T classification. If we're dealing with intracartilaginous tumor spread, then the laryngeal cancer is classified as T3. However, if the tumor penetrates through cartilage and extends into the soft tissues of the neck, then the laryngeal cancer is classified as T4. In addition, neoplastic cartilage invasion affects prognosis, and it has been shown that glottic cancers with neoplastic cartilage invasion have a poor prognosis as opposed to glottic cancers without cartilage invasion or only with inflammatory findings within cartilages. Last but not least, treatment is also affected by the presence or absence of cartilage invasion, and in many institutions, whenever there is massive cartilage invasion, total laryngectomy is still performed. What is the CT and MRI aspect of laryngeal cartilages? Hyaline non-ossified cartilage, it has a low signal intensity on all MR pulse sequences, and it is relatively dense and homogeneous on CT. Ossified cartilage, however, behaves like bone, so we have a cortex with a low signal on all MR sequences and with a high density on CT, and a marrow cavity that mainly contains fatty tissue. So you will actually have on MRI a fatty tissue signal in normal ossified cartilage. Normal ossified cartilage also does not show substantial enhancement. Now, what are useful CT criteria to detect cartilage invasion? These are criteria that are either highly sensitive or highly specific. They include sclerosis and erosion or lysis. If sclerosis or erosion or lysis are present at imaging, then tumors are upstaged as T3. Extracartilaginous spread means that the entire cartilage is destroyed. Tumor has spread through the cartilage into the soft tissues of the neck. In this case, the tumor will be upstaged as T4. And we also have other criteria that have been described in the literature. They are, however, not useful, either because their prevalence is very low or because they are non-specific and non-sensitive. These criteria that are not useful include serpiginous contour, bowing, blowout, and many more. The most sensitive sign to detect a cartilage invasion with CT is sclerosis. Sclerosis, however, is not a specific sign. What does sclerosis mean? It means that we have an increased density of a cartilage in immediate tumor vicinity. As you can see from this true positive case of a glottic subglottic tumor on the right, the right cricoid cartilage is sclerotic. We're capable of picking up microscopic invasion into the cricoid cartilage because tumor vicinity has induced inflammatory findings as well as osteoneogenesis in the adjacent cricoid cartilage. So sclerosis is actually an indirect sign to detect cartilage invasion. Because sclerosis corresponds actually to an increased number of bone trabeculae and it is an indirect sign to detect cartilage invasion, it is also false positive in a considerable number of cases. In the false positive case shown on this slide, you see that the cricoid cartilage is highly sclerotic. However, if we look at the histologic slice, we see that the tumor has even not invaded the perichondrium of the cricoid cartilage. In the cricoid cartilage, we have, however, an increased number of bone trabeculae due to induced osteoneogenesis. As opposed to sclerosis, which is a sensitive but non-specific sign to detect cartilage invasion, we have specific criteria for tumor invasion on CT. These include erosion and extralaryngeal spread. You have here an example of erosion of the cricoid cartilage, and you see that an erosion corresponds visually to a punched out area in the cartilage that's surrounded by a sclerotic cartilage. Finally, extralaryngeal spread corresponds to complete destruction of the cartilage and extension into the soft tissues of the neck. It is also a very specific, however, a very late criterion for tumor invasion. It is important that you do not confound erosion with non-ossified cartilage. Erosion is a osteolytic area. It is a punched out lesion that's surrounded by sclerotic cartilage, as you can see in this glottic subglottic cancer, whereas non-ossified cartilage typically has a slightly higher density than the adjacent tumor. You have here an example of a supraglottic cancer. You see that the adjacent thyroid cartilage is slightly denser than the tumor. How do we diagnose cartilage invasion on MRI? Neoplastic cartilage invasion manifests as a low signal intensity on T1, as a moderately hyperintense signal intensity on T2. This is what has been called the evil gray, and a moderate enhancement after administration of gadolinium. This is a characteristic example that you see here, a bilateral advanced glottic cancer. You see that the anterior portion of the thyroid cartilage has a low signal intensity on T1, a moderate signal intensity on T2, similar to the signal of tumor, and a moderate enhancement after gadolinium. This is another example of cartilage invasion detected by MRI, a more subtle example. This was a patient with bilateral glottic supraglottic cancer. The arrows point to an area of focal intermediate signal intensity on T2, low signal intensity on T1, as well as moderate enhancement after injection of gadolinium. And this proved to be invasion into the thyroid cartilage, as you see from the corresponding histologic slice. MRI has the advantage that it can differentiate between neoplastic cartilage invasion and inflammation within cartilage caused by tumor vicinity. As opposed to tumor invasion, inflammation in cartilage typically shows a higher signal on T2 than the signal of tumor and a much stronger enhancement. You have an example here of a patient with a piriform sinus cancer. The adjacent thyroid cartilage is sclerotic. On T1, we have a similar hypointense signal in the tumor and in the adjacent cartilage. After administration of gadolinium, we see that the enhancement of the thyroid cartilage is much stronger than the enhancement of the tumor, and on T2 the tumor has a moderate signal intensity, this evil gray, whereas cartilage has a much higher signal intensity. All these findings suggest inflammation. And here you have the corresponding histologic slices that show you the tumor as well as only inflammatory findings within the thyroid cartilage. So when should we use MR to detect cartilage invasion? It is extremely helpful if surgical treatment is planned and laryngeal cartilages are very irregular, sclerotic on CT. You have a typical example here of a patient with a glottic cancer on the left-hand side. You see that the adjacent thyroid cartilage is sclerotic and also appears very irregular. Also, the arytenoid is sclerotic. If you look at the corresponding T1 fat-saturated contrast-enhanced image, then you see the moderate contrast enhancement of the tumor. However, the thyroid cartilage does not show any enhancement at all, so there is no invasion in the thyroid cartilage, there is no inflammation. In the arytenoid cartilage, however, we see very strong enhancement, which is stronger than that of tumor, so we're dealing here with inflammation in the arytenoid cartilage. Extralaryngeal spread affects T classification, prognosis, and treatment. MRI is in general superior to CT for the detection of extralaryngeal spread, as you can see from this example of a patient with a subglottic cancer detected on both CT and MRI. However, the tumor has spread into the soft tissues of the neck. It is seen outside the cricoid cartilage, and this extralaryngeal spread was missed on CT, however detected on MRI. Extralaryngeal spread can occur not only through the laryngeal cartilages, but it can also occur through the cricothyroid membrane. This was the case here. Alternatively, extralaryngeal spread can occur through the thyrohyoid membrane. This is the case in supraglottic laryngeal cancers. You have here two examples of extralaryngeal spread. In the patient image with CT, there was massive extralaryngeal spread. In the patient below, imaged with MRI, there was only minor extralaryngeal spread. Just a few words about laryngoceles and squamous cell carcinoma. Laryngoceles are dilatations of the laryngeal ventricle or ventricle of Morgani. This dilatation is caused by obstruction of the ventricle either by a tumor or by an inflammatory process. Whenever the laryngosele is limited to the larynx, we speak of internal laryngosele. As you can see here, two examples of internal fluid-filled laryngoseles. Whenever the laryngosele extends through the thyrohyoid membrane into the soft tissues of the neck, we speak of external or mixed laryngoseles. All laryngoseles can either contain fluid or they can contain air. Laryngoseles can serve as pathways of tumor dissemination into the neck. This is such an example. Within this external laryngosele, there is some fluid that presents as having a low signal on T1, high signal on T2, and there is no enhancement. In addition, however, we see that within the laryngosele, there is a tumor with an intermediate signal on T2, low signal on T1, and enhancing. This is characteristic for squamous cell carcinoma spread within the laryngosele, and from this external laryngosele, the cancer can get access into the soft tissues of the neck. In the end, just a few words about non-squamous cell tumors. Most of them are located beneath an intact mucosa, as you can see from these two images here. Therefore, the role of imaging is to detect these lesions, to try and characterize them, to precisely describe submucosal tumor spread, and to guide the endoscopist where to perform a biopsy, because very often repeat biopsies are negative. There are many different histologic types of non-squamous cell tumors. The most common are chondrosarcomas. Chondrosarcomas of the larynx typically arise in the cricoid cartilage. There are local invaders, and the treatment of choice is function-preserving laryngeal resection. On CT, they have a characteristic appearance with popcorn calcifications, the chondroid matrix, but sometimes they can have tiny calcifications, making diagnosis at CT quite difficult. On MRI, chondrosarcomas typically have a high signal intensity on T2, low on T1, and they have variable enhancement. Most often the enhancement is not very pronounced, as chondrosarcomas of the larynx are most often low-grade, grade 1 or 2 chondrosarcomas. What's also typical for chondrosarcomas of the larynx is that they show no restricted diffusivity. You have here the example of a chondrosarcoma arising in the cricoid cartilage, involving also the cricoarytenoid joint on the right. The signal is quite high on T2. There is important enhancement after gadolinium, and on the diffusion weighted sequences you see a high signal on the B1000 and high signal on the ADC map, so no restricted diffusivity, which is typical of chondrosarcoma. So, in conclusion, if you image squamous cell cancers of the larynx, you should know the key anatomic structures as well as the appropriate terminology according to UICC AGCC guidelines. You should use a checklist for sites, subsites, spaces, cartilages, and the neck. You should be aware of pitfalls and limitations of CT and MRI, and also be aware of therapeutic implications. For non-squamous cell cancers, in addition, you always have to bear in mind that as they can be entirely submucosal, your role is to detect them, to try and characterize them, and to guide the endoscopist to the most appropriate biopsy site. Thank you very much for your attention, and if you have any questions, do not hesitate to contact me.
Fantastic. Thank you very much. Thank you for an excellent presentation, Minerva. Are you there? We'll just try and get her back online.
Yes, absolutely.
Amy's with
Both
us.
presentations were beautiful, absolutely beautiful. I truly enjoyed the histological correlations to pathology and anatomy. Amazing, amazing case collection. Thank you for sharing those with us. And we actually do have a few questions. One of the questions is, where do you see value of artificial intelligence in head and neck imaging?
So this question is for me or for Amy or for both?
I think for both.
For both, very well. To be honest, I don't think that for the time being we're close to a practical everyday use of artificial intelligence, in particular in imaging of laryngeal cancer. It is, I think that there are many good applications for artificial intelligence in radiology, in other oncologic fields, and also in the emergency setting. We have program, we use it. But the experience until now, in terms of head and neck, it's not very much substantiated by data yet. So I think that we still need our eyes and our brains. So we won't be replaced that easily by artificial intelligence in the head and neck.
I think I agree with Minerva. I think head and neck is hard because the parts are very small, and I think there's a lot of variability. For example, with Dr. Becker's talk with the cartilage, it's really hard to standardize and say if it looks this way, it's this. If it's that way, it's that. So I think, I'm hoping that what we do is complex enough that we have some job security. And I'm not an expert in AI, but I think a lot of the things so far, in terms of interpretation, not in terms of triaging cases to sort out what's urgent or not, a lot of it is there's well-defined criteria, like a head bleed, it's really white on a CT as opposed to, darker. Or a lung nodule is white, compared to lung. So it's a bit more contrasty, and I think that's hard in head and neck because it doesn't work that way, which is good for us.
Very true, very true.
Perhaps I just have a comment. In terms of research, what's interesting, where I believe that artificial intelligence, but in terms of radiomics and texture analysis, where this really could be beneficial, for example, by analyzing images on diffusion-weighted sequences or standard morphologic imaging and trying to find out certain patterns of the texture that might help you to predict response to treatment. So right there is a lot of research going on. So I think that this is really very promising. But in terms of everyday diagnosis, we're not there yet.
Agree, completely agree.
We have a question here. Oh, sorry.
Yeah, go ahead.
You're being asked, could you please share your larynx MRI protocol? Now, you probably will share it later in writing and we can distribute it on Twitter. Would you like to share with us at the moment what would be your main protocol?
Okay, so as I said, I'm willing, I can share the protocol. We have different vendors and different MR machine field strength. So depending on what machine you have, I can give you exactly the exam card so that you have exactly the same parameters. But in general, there are a few things that are quite important. For example, we ask the patients to breathe freely, if they need to cough and swallow, to do it before we start the acquisition of the sequence. Also, we always use an anterior-posterior direction for the face encoding. We use saturation bands for the vessels so that you don't get too much flow in the vessels. And also we use parallel imaging techniques so that you have a minimum of two acquisitions. And in parallel imaging technique, we don't use a very high factor, so perhaps like 2, but not. We wouldn't go to optimize above all the duration. The other thing is I don't use fat saturation on the T2 weighted sequences. I don't know if you saw this. Because fat saturation, especially in the lower neck, you can get You can get water saturation instead of fat saturation. And so especially in patients that have thick necks. So, and I keep the examination as simple as possible. So I use T1, T2, T1 GADO, then I subtract, and one additional sequence, usually diffusion. I've started now also a protocol using routinely perfusion. But I'd say for the standard diagnosis, this is about like 4 sequences, and the examination should be finished in 20 minutes, not more. Don't keep your patient too long on the MR machine.
That's a good tip, thank you.
So I have a question to both speakers. Do you prefer CT over MRI, or is it individual dependent, which technique you prefer?
Okay, we prefer MR because we are more precise at diagnosing extralaryngeal spread. We pick up cases that we simply don't see extralaryngeal spread on CT, and you much more easily see it on MRI. And also because when our surgeons want to do surgery and partial laryngectomy, they just want to make sure that we have a very precise mapping regarding cartilages, and that the cartilages are normal or that there is some inflammation. So that's what usually we use MRI. However, if patients cannot cooperate, and this happens in like 10% of cases, sometimes 15% of cases, we have some series where we have more patients that cannot cooperate, then I use CT. But usually I start with MRI.
For us, we generally start with CT. That's our workhorse for neck imaging, and it gives us an overall idea for what we're dealing with. And then we use MR as problem solving if there's any questions with the cartilage. But a lot of times it's just really hard to get, I mean, I need to learn from Minerva to get the beautiful images, because if there's any motion, if they can't lie still that long, if there are airway issues because they have a larynx problem, it's harder to get really nice images. But we definitely do use it for problem solving with cartilage. We also try to do a dual energy CT to look at the cartilage, see if there's tumor invasion. But again, you know, it's sometimes hit or miss depending on how big the area is for you to look. But shifting the KEV up generally helps you get an idea for, you know, whether the iodine drops out and you get, you know, cartilage.
So when you compare dual energy imaging with MRI, what is your experience in regard to sensitivity and specificity?
Just anecdotally, just from experience, we still do use MR more so than dual energy. Dual energy is a bit of a work in progress, but sometimes just complementary. We do both because all our CTs are done with dual energy technique. So we can always, after the fact, go back and get the different KEVs just to take a look. And if, you know, there's an agreement between dual energy CT and MR, that's really the best.
We've had a couple of questions on the use of superficial coils or surface coils. Do you have any comments for that, either of you, on the use of surface coils?
Okay, regarding surface coils, they give you just superb images. But as I said, we usually stage laryngeal tumors with MRI, so I won't do a CT before or after. So I need to image the lymph nodes. If I have, however, a CT, then I will do the MR of the larynx using surface coils, because then I know what I need to focus on.
Okay.
We got surface coils just within the last year, and there are these small interlocking things that you place on there. And because we, for the most part, patients already have had a CT, then we do the very small field of view with the surface coils, and you can get really beautiful images. So we have been using those for our larynx protocol.
Very nice. And one other person was wondering if you wouldn't mind to explain again the difference between cartilage inflammation versus invasion.
Okay, no problem. So in vicinity of tumors, there is a large inflammatory rim, and this inflammation is induced by substances, very often prostaglandins and other cytokines and mediators produced by the tumor. So what happens is that in the laryngeal cartilages, the inflammation precedes actually the invasion of the cartilage by tumor. So when the tumor is very close to the cartilage, you first have inflammation, and only in a later step you will have tumor invasion. In terms of prognosis, and there were several papers on it, it was shown that if cartilages have inflammation, they more or less behave in terms of prognosis in a similar fashion as if cartilages were normal. However, if there is tumor invasion in the cartilage, patients will have, following radiation therapy, a higher rate of recurrences. So in terms of imaging, we just look at the signal of cartilage and tumor. So if on the T2 weighted image, the signal intensity of cartilage is much higher visually than the signal intensity of the tumor, and if after gadolinium administration, the enhancement is much more pronounced in the cartilage than in the tumor, then we call this inflammation of the cartilage. However, if they are similar, so you have this evil gray, this intermediate signal in cartilage and in tumor on T2 and after injection of gadolinium, now this is cartilage invaded by tumor. So
Thank you.
I think most of the ones that I can see have been covered. There's one person asking if there is tumor adjacent to the cartilage, isn't that cartilage going to get radiation anyway, as most patients resist laryngectomy? So does it help to differentiate cartilage invasion?
Well, yes, it helps because you have also in many institutions the surgeons doing partial laryngectomy. So not all laryngeal cancers will undergo radiation treatment. Some small laryngeal cancers will undergo partial laryngectomy. In other institutions, you would use radiation therapy. So this is useful. And what I haven't talked about in this lecture is that once you have recurrence after radiation therapy, and from our experience, we see the same patterns of signal intensity changes in irradiated cartilages as in non-irradiated cartilages. So if you have recurrence after radiation therapy, then some surgeons will still try to do partial laryngectomy instead of total laryngectomy, because this is the only option that it is. So I think it very much depends on also on what your surgeons would do.
Thank you. I have one more question. What is your preferred method of imaging the post-treatment neck?
We do MR. MR with diffusion weighted imaging routinely, and we're just more confident in differentiating post-treatment changes, benign post-treatment changes from recurrence. This is really, it works very well.
Amy, do you have another answer to this question?
Generally, for surveillance, we still do CTs. You know, if there's good spatial resolution, we're not as limited by artifact with motion, but anytime there's a question, then we move on to the MRI.
Okay. I think that wraps up our questions. So, I mean, as I'm sure Minerva, you've been able, and Amy, you've been able to see in the column, there's been so many positive comments thanking you for excellent presentations. I can't read them all out. I'm sure you understand that, but you can read them and you can see them, and you know, they are very, very pleased with both the presentations. So thank you so much indeed. So it just leaves me to say thank you for the first webinar. Thank you so much for speaking and making this success. And you know, we really hope for this collaboration to continue.
Thank you. Agree.
Thank you so much.
What a great
Thank you
way.
so much.
Bye.
Bye. Great.